Good morning, everybody. Welcome to our conference today. Thank you for joining, and hopefully, we should have a good conversation today as we tackle health inequalities and how we can try to narrow the gap. I'll bring in Cicely to just say a quick hello, and then we can start if she shares the screen for me.
Oh, hi. Good morning, everyone. Lovely to see you all. Our year's annual conference comes around very, very quickly. I can't believe we are already, coming to April. We have been waiting for this, given the experiences that we have all had, and it would be nice to hear what that has translated to from, when we talk of meaningful community engagement, because it's what has kept us, so to say, but we're going to hear more on that. So I'll share the screen, Eva, for you, or the slides for you.
Thank you, Cicely. Okay, so today we're going to be looking at the topic of health inequalities. And we're going to have people talking about health inequalities just to see what the feel is in our communities. And we have wonderful speakers lined up as well today. So, a very packed program. And thank you very much for attending. So, health inequality is unavoidable, unfair, and difference in health status between groups and communities is not good. And as we've seen, because of COVID, this has actually widened the gap. So we need to look at why this has happened and what we as a community are doing to avoid this. Next slide for me, Cicely. Thank you. So today we're going to be talking about meaningful engagement. What does that mean to us in addressing health inequalities? Um, and on my slides here, it's got what we need to, some of the things that have come out that we need to see happen. So use of plain language, information sharing, transparency, having dialogue as we will do today. Attitudes and behaviors have to change, having active listening as we're going to do today. And most crucial of all is building relationship between the different stakeholders. Um, thank you for that, Cicely. So I have two wonderful ladies who are going to help me today. We have Kasia and Ravina. And to enable us, hi, to enable us have more of a conversation today, they will be taking us through the polls. So for you, for people who are new in our Thursday conversations, we normally have 2 or 3 questions, and then you'll take a poll just to see what people's feelings are, and then we'll encourage people to have a dialogue about what the questions mean to them. So, Kasia and Ravina, if I hand this over to you.
So we're just going to launch the poll.
Oh, okay.
So we're just going to launch it now, and we'll give you like 3 minutes to think about them and then complete them.
We still have a few people just joining. So for the people who are joining, we're just at the point where we're doing our polls. So we've got a polls on your screen. If you could answer the questions, that would be, thank you.
So just a couple more seconds. It looks like we've got most of everyone in, just waiting on like a couple of people. Okay, so I think we'll close it now. Right, so I'm just going to share the results with you now. So, let's start with the first question.
Yeah. How important do you think meaningful communities engagement is to address the health inequalities that exist? So 92% of you said 100, 58% of you said 50, and 0% of you said 10. Does anybody want to start speaking what their thought?
Sorry, are you asking for comments?
Yeah. We're just curious. We're just curious to see why such a high percentage of people responded to 100%. We just want to hear your thoughts about the responses, basically. Yeah.
Well, I mean, I would say that you can't affect any change anywhere in society without engagement. I mean, if you don't have engagement, you won't get change. Certainly won't get change you want. That's my personal view.
Yeah, that's so true. Lorna, you have your hand up. Do you want to speak?
From my perspective, being an LGBT support service, I have to engage with other communities from different backgrounds, from different disabilities and all sorts of areas to understand the challenges you already have, let alone being LGBT. So, because I can't be for everything, but I can engage and be supportive to make sure that we have a stronger knowledge and support mechanisms, not just for ourselves, but also for you. And so that when we go for funding, we know that certain areas need extra support to deliver what they need. So that's from my perspective, though.
Thank you. Thank you so much. And Esther?
Yes, just like the other two previous speakers have said, it's quite important to engage the community because the community, that is where the challenges lie. They understand what the challenges are. On the other side, in the community, that is where the solutions lie. And so unless the communities are engaged meaningfully, then no meaningful change will take place. And hence, there is every reason why the community needs to sit in the steering seat because they understand and they have the solutions.
Yeah, that's very true as well. Like if you want something good to happen to the community, you have to listen to what people's issues are and what they care about. Yeah, thank you for that. Does anyone else have anything else to say? Yeah, Nisha? Oh, you're muted.
Oh, yes, okay. Hello, good morning, everybody. Yes, for me, community engagement is very, very, very important, even more than 100%, put on 100%, because as Esther said, each and everything that we do here, like whether this is from the service provider perspective or service user perspective, so the community always lies in the center. So without involving them in any activities or event or decision making or like strategy or like using the services, accessing the services, and providing the improving the service delivery from the service provider side, I mean, we cannot imagine the success. So if we are there not using the not like with the community and not thinking about the community, it is just like they go away, I'm not needed kind of thing for me. Thank you.
Thank you. And sorry, I don't know what your name is, but you've got your hand up as
Oh,
well.
Martin.
Hi.
Thank you. I'm Martin Ewick. I'm the chair of Berkshire Healthcare. So, and I have a particular interest in working with minority communities. Now, the trust is trying to work out how to engage better with minority communities. And I think it's really important. What I've learned from talking to colleagues across Berkshire is my own understanding how difficult it is sometimes to understand the perspective of people who come from different backgrounds. And so I'm very keen to encourage this engagement and to hear from you what we can do better, how we can engage those communities, how we can learn more, and also how we can work with our partners outside the health service, the local authorities, with the housing, with employment, because I think all these factors have to come together to really help communities lift their game. And I don't think we can just solve it just by health alone, although it's an important part of it. So I think I just want to encourage everyone to recognise that we're very keen to hear from you, and we're very keen to learn from you. And I think perhaps with Cicely's expert help, and indeed James, we can collect some of those issues and get us, make sure our strategy enables us to engage and learn. Because I think, as I think Esther said, that some of these things are you know best about, of course. Some of them actually within your hands, and we can help support that. But rather than just talk about it, I want to sort of try and move us as fast as possible to real action. So that's just a sort of a saying we're very open to hearing your views and to try and work with you. Thank you.
Thank you for that. Does anyone else have anything to add to this point? If not, we can just move on to the second question, which was, how well do you think communities and services engage with each other in addressing the health inequalities that exist? And 4% of you said 80%, and 67% of you said 40%, and then 29% of you said 10%. So it'd be really interesting to hear why you picked what you did. Anyone want to start?
Yeah, I'll start.
Yeah.
I don't think they do.
Mm-hmm.
Oh, I can't remember what I was going to say now.
That's okay. It's okay. We can always come back to you if you want.
Yeah, no, I don't think they do, because it's very hard to explain and find someone who is either willing to listen or has the time to listen.
Mm-hmm.
So, like for me, I have very complex health needs. I've got complex post-traumatic stress disorder, and I have fibromyalgia, which is also another really complex thing to have. But trying to explain various things in the way the system is set up makes it like really difficult, because like my condition especially, I know there's lots of other conditions, but obviously I only really comment on my own. Like there's so many different, there's like over 200 symptoms, and it's not a consistent illness. There's so many different things that happen on so many different days, from like second to second. Like, so people want, like, you know, they want to know in advance if you can't do something or if you can't be here. But you can't predict what day you're going to feel like that, what day, how much pain you're going to be in next week, because you don't even know how much pain you're going to be in the next 5 minutes, or if you're going to be in pain at all. Like there's not enough time and allowance to accept all of the various things that are out there.
Yeah, thank you. Yeah, I feel like sometimes there isn't like enough of a support system of like understanding to help people, like especially like employees. Sometimes it's probably quite difficult to find that kind of support and still be able to work.
Yeah, and people say they want to support and they try to offer support, and they think just because they've heard you that they've been understanding, but things don't change. You know, because I
Yeah.
have an autistic son as well, so we have inconsistencies with being on time for school and things like that. And
Yeah.
then they're throwing at me the importance of everything their end, but
Yeah.
I can't change anything my end
Mhm.
to suit them. So that the understanding and support stops after a while because you're not conforming to what they want, because,
Yeah.
even though they feel like they've done what they need for you.
Mhm. Yeah, I understand that situation. Had a similar thing happen to my family as well, so I know what you're talking about. Yeah, yeah. Thank you for
Thank
that.
you.
Lorna, you had your hand up as well.
My perspective is exactly what that lady's saying, which is it comes down to capacity within your organisation and bandwidth to actually keep engaging with other organisations on a regular basis. Because I could be, well, I am. I'm inundated by all areas of society requesting support around LGBT inclusion and support. But it's down to bandwidth and that organisation deciding whether you are the one that they want to engage with and that they're ready to, that they have the bandwidth to make change, to support all of their service users or running. So they're busy running their services. It's not a slight in any way that they're not trying to put you, dismiss you. It's just that they won't have capacity and they've decided which areas are important and then make their engagement, which is why it's 10%, because there is engagement, but it's a very small pockets amount because we can't all make change massively in a big way because it's just impossible, especially if you work with certain demographics, which is gender and sexuality, whether it be disabilities, whether it be, we're all in those categories. Any of us can be in any of those categories. So we're going to be stretched and we'll have to make our decisions of which is more important as an organisation for us right now.
Mhm. Yeah, yeah, that does make sense because I guess you can't do everything right at once.
Yep.
The capacity for what one organization can do
Mm-hmm.
is restricted
Mm-hmm.
to some extent. Yeah, thank you. And Alice, you had your hand up as well.
Hi. One of the things I would turn around and say is community engagement is as engagement is, it could be community orientated, not statutory orientated. You've got to go where the community is and at the time that's convenient for the community rather than doing it according to the times that statutory organizations are working, because you're not going to get good engagement that way.
Mm-hmm.
And you're not. And also you need to listen to the community. They know the problems, but also share with the community what you want from the community. Because sometimes the language that you use is not appropriate to the community. They might not understand. The terminologies are very different. So you need to go to for the needs of the community, not the needs for the statutory, if you want to get good results.
Mm-hmm. Oh wow, yeah, that's such a good point. Thank you. And Esther, you have your hand up as well now.
Yeah, just a quick comment, like what Alice has said. Get into the community, just to get to where the community is, because there is this saying that we have the hard to reach communities, but the question is the mainstream services, or are the mainstream services working hard enough to reach these communities? We've been doing research here in the Southeast region, but here in Reading, we even have some researchers here in the forum, and we have some Joanne from Health Education England who has been seeing this research. We have been able to use the local community researchers to do research, and that is a little bit not what happens, because normally we have bottom-down approach, but we use the local community researchers to engage with the community, and they were able to reach the community. And I want to say that they may not have the research skills, for example, but they have additional benefits like they have the trust with the community, they have a relationship with the community, they have rapport with the community. So using the local community leaders to reach the communities, they have the language that they can be able to speak. So I think that approach can be able to narrow the inequalities that we are talking about. Thank you.
Mm-hmm. Thank you so much. Thank you. Does anyone else have anything to say? If not, Kamal, do you want to say something?
Thank you. I mean, I'm going to talk to you as a group in a moment anyway, because I've got a presentation. But having been the lead of patient and public engagement group in West Berkshire for over 12 years now, I think. I've stepped down this year because I've got a new job. But I think one of the things that, I mean, everything your speakers and your members are saying is correct. Everybody needs to listen. We need to come to you. We need to listen continuously. We need to have a relationship. It can't be, oh, we're looking at this service and therefore we want to hear your views now. It should be continuous. But in order for it to be continuous, you need to make sure you've got resources there that can actually deliver that. And so that's something I fought with for my entire time. You know, I was given 1 day a week to engage with the community. And I mean, it's ridiculous really when you think about it, because if you even try and set yourself a task to try and meet with lots of different people, different groups, go to different events, I mean, it took me 10 years to get established, you know. So, and I'm not saying I didn't add value before then, but I think there's something about being present, about showing up, and about keep showing up that buys a little bit of investment in you as an individual, because you're trying to do it genuinely rather than pay lip service to whatever it is that needs to be done.
Yeah, thank you. Sounds like it's what you're saying is it's about like the quality and long-term relationships, and that sounds like a very important thing with engaging with communities. So thank you for that. And Liz, you have your hand up as well.
Hello, hi. I'm new
Hi.
here. Thank you very much for having me. I represent a dance charity in Reading. We do lots of work across the community, trying to support people to access movement for their mental and physical health. And I think from an arts perspective, I really want to echo what the last person, Kamal, just said, that certainly for arts organisations, we are constantly in competition for funding with one another, not intentionally, but because we're grant funded. So we go from project to project, which means that you can't do meaningful community engagement easily, because we have, 6 months, a year, if you're lucky, 2 years of funding, and then we have to apply for new work. The same funders like the Arts Council won't fund the same projects time after time. And so it makes it really hard for arts organisations to do meaningful engagement, and you end up with loads and loads of tokenism, which exacerbates the problem. So we really need, as an arts sector, we really need to be looking to areas like health funding, where there is more continuous funding, or where we can access service contracts or contracts with local authorities. And I think, touching back on the first question that you asked in your poll as well, one of the problems is that we work with the people we know, because they're safe and they're familiar and we know how they work and we all speak the same kind of language, and we're not branching out to working with other sectors and other organisations in the way that we should be. And all of that kind of comes together to make a perfect storm of tokenism in the way that we engage with communities. And that's a real problem for us to address, particularly organisations like us, in the way in which we access and work with our communities. And I think, I think there needs to be some fairly radical change in the sector in order for those issues to be addressed. So it's really interesting to hear what everybody's saying. Thank you for your thoughts. I'm learning lots.
Thank you for that. No, I come from an arts sector as well, so I've got some experience, and I know exactly what you're talking about. And this is like also exactly the kind of thing I'm really interested in is expanding that community engagement capacity, and for it not to become like a token thing, because I've definitely fallen for that in the past as well, because you kind of need to like come up with projects really quickly, because otherwise you're going to miss out on that funding deadline, and then what are you supposed to do? So yeah, thank you for that. Does anyone else have anything to say? If not, I'm going to pass it over back to Eva. I think we've got a video.
Yes, thank you for that, Kasia and Ravina. Cicely, are you able to upload the video for us? We're just gonna have a look at what some people did say from our community in terms of what they think community engagement is about. And then we'll have Victor from ACRE give us a word.
Stop. Come back again.
Yes, please.
Health inequalities are avoidable, unfair, and systematic differences in the health outcomes of the populations that we serve among different communities. This should not happen because it only widens the health inequalities gap. Together, we can narrow that gap by meaningfully engaging with our communities. What that means is getting to know our communities really well.
For me, community engagement is understanding the voice of the community people, which brings a lot of value. For any community engagement, this has to be done together with the people, the work done by the people, and the work is for the people. This brings total belongingness to that community engagement.
Health inequality is a very important issue needed to be raised, discussed, and addressed without fear or prejudice to improve the quality of life. And that could be done by allowing the community to have a voice to speak.
By getting to know our communities well, we're able to build strong relationships with people, which allow people to feel like they have a voice and a say in things. And by doing so, they're able to have more authentic conversations about the issues that they have, for example, health inequalities.
So for me, community engagement is a process of working together to address the needs and issues that affect the well-being of people. Now that should bring about positive change. It should highlight the trust that has to take place between people, and it's also an understanding that community engagement is a long-term process. So it's in a way, in a place like Reading, it shifts the focus from the individual to the collective. It focuses on the cultural diversity of the place and inclusiveness. But overall, it is about taking action to address the needs and issues of communities, and also then, and through that, build and sustain relationships.
To me, well, in my position as the manager of ACRE, I see it as a process by which frontline agencies like ours can engage with community groups and individuals and build a lasting and healthy relationship with them. And that enables us to understand the issues affecting those communities, and then working collaboratively with them to devise self-help solutions on how they can address some of those issues. And where they are unable to, then engage or refer to other public or voluntary sector partners.
Inequalities are avoidable. They are not healthy. And we need to prevent these health inequalities. Research has been done, and we know the factors that are contributing to health inequalities. We all need to work together and address these health inequalities, because by addressing these health inequalities, our communities will thrive. The world will be progressing. Why don't we be intentional, each and every one of us, and work together and reduce these health inequalities. I'm so grateful that today we are focusing on health inequalities, and we need to talk more on health inequalities and how we can prevent them. Thank you so much. Let's work together.
Thank you for that, Cecily. So I'd like to invite, we've got a number of guests coming to speak to us today about community engagements, to tell us about the strategy they've set up, what challenges they're facing, and what is happening around in our community. So the first speaker we're going to have is Victor, who is the chair of ACA, manager of ACA, Alliance for Cohesion and Racial Equality. So Victor, this is your time. Can I request our speakers? We've got a packed program today, so maybe about 5 to 6 minutes each of you. Thank you. Do I have Victor in the house? Oh, there we go, Victor. But I can't hear you, Victor. I wonder if everybody else can hear you.
No, it's muted.
I think he said he was with the coming in, which he did, but I don't think he can now speak.
Hello.
Oh, there we go.
Fantastic. I can hear you now, Victor.
Okay. Yeah. I was saying that welcome to this Health Equalities Conference, which is where I deviate and say Health Inequalities Conference. Because the truth of the matter is we're trying to highlight issues that are affecting individuals and communities. And I'm happy that, year after year, we're discussing what those issues are, what the new approaches are, and some response and support is received from public services. Last year, I wasn't able to attend, but I did send a message and I said, I wish that when we met this year, I would say, well, we haven't got any health inequalities, but sadly, that is not the case. The issues still persist, not by design, but there are issues that are endemic, and they would only go away when we work together. Public services, voluntary sector organization, community agencies, individuals, because it's about us. It's how things affect us in relation to accessing health services. And just generally trying to promote healthy living and having a, proper well-being, a feeling of well-being. Over the years, in my speech, I've challenged public services, and over the years, somehow they've responded, albeit with small gestures, but responded all the same and very much welcome. Hopefully we'll get there someday when my dream of health equalities would have been achieved. So what have we been doing in the past year? We received, from the back of these conferences, we were invited to apply for funding, and we received small funding from NHS charities to pilot a community wellbeing hub. Now, we had started that pilot process for the last 3 years without having the resources to do the actual implementation, but we were doing things piecemeal, and they were taking hold. And particularly, there were the weekly meetings, which we've been having now for over 2 years. They were meant to be monthly, but then they became fortnightly and became weekly. And somehow we are all hooked on them because they provide very good information and support to us that attend these meetings. They're on every Thursday between 11:30 and 1. So please, after this meeting, don't go away. I would love to see you again next week. Now, the hub, after the lifting of lockdown, has started, holding activities. We have a coffee morning every Tuesday morning, for which, BHFT have kindly provided a CBT professional to be at the meetings to help individuals who have particular problems. These are face-to-face meetings, And so the program is varied. We've had art therapy as part of the session. We've had games. We've had, talking about issues. So please spread the word around that this has started as a way of pulling people back from the isolation that we all felt during lockdown. We also we had started an employability support sessions which run every fortnight on Saturday from 2:30 p.m. for an hour and a half. And that has also been very popular, which attracts an average of about 20 people during those sessions. We're doing these as a means of providing alternative support to individuals, because one of the points that we've been raising to public services is that yes, it's well and good that you've got the services that you've provided, but for some reason, some people find it difficult to access those services. So use us in the voluntary and community sector as a gateway into communities, so that when like for example, our sessions are open, and any service that wants to engage with the communities can come, and we'll give them a platform to be able to do that. Health campaigns will be involved in the vaccine campaign. We've hosted the Health on the Movement here at ACA, as part of the hub activities for 4 sessions. And we're planning more, given the fact that, there are some people who are still vaccine hesitant. We've engaged with BHFT, and they've agreed to place their health check clinics, adult health check clinics here at the hub as part of an outreach program. Unfortunately, I've been away for the last few weeks, and I haven't engaged with the officers yet to know what the referral procedures are. But when I do have that, I'll share that information so that that there are things happening here at the Oxford Road Community Center, which are delivered as part of a hub. Now, the whole concept of the hub is because, like I said, not everybody is comfortable about accessing services that are delivered in specific places. But if you can deliver those same services in places where they feel comfortable, places that they go to, regularly, then there's likelihood that you'll be able to reach those people. And I agree with the comment that Esther had just made. People are not hard to reach. And I remember a couple of years back where we had a community football tournament, and the BHFT director came, and the MP and the MPs were there, and the chief of police. And I said, well, time and again I hear this comment, people are hard to reach. I said, well, here they are in their hundreds. You can reach them. Find out where they are, where they congregate, and what they do, where their interests are, and you reach them easily. And again, I offer the hand of partnership on behalf of ACA and our community support partners, Utulivu, Mojatu, Sudanese Community Association, Ready Muslim Council. The number is endless. We've got about 74 different organizations that are members of ACA. So please, that's the word I want to leave. We're here. We're prepared to work in partnership. Sometimes, yes, we will knock on your doors to get, to ask for help, a little bit of seed money, a little bit, deployment of staff, placing a service here or delivering a service through us or via us to be able to reach to the appropriate individuals. And yes, I think that is my pitch for today. And I still hold on to that dream of us having health equality. So I can ditch the inequality aspect of my talk. Thank you.
Thank you, Victor, for reinforcing so much that has been said through the clip, but also the voices and the many voices we are yet to hear. But at this point, I know you've referred a lot to BHFT, and we have good evidence with us. Yes, we have had in the past. Martin, as the chair of BHFT, has relentlessly talked about the need to engage with the communities. And having the hub there is an indication of how much they can do, because they are the backbone of the NHS charities funding that ICA received. So Martin, I know you're saying hello. I'll be great to hear you and the good work that you continue to do as a health organization. And also your big experience, huge experience on the health inequalities.
Cicely, thank you. First, just to say it's a pleasure to be here and to hear your views. As I said earlier, I think it's really important that we at BHFT and indeed the other organisations really understand different communities' perceptions, because my experience in listening to, for example, our ethnic minority staff in the trust, I've learned an awful lot, which I thought I knew already, but I didn't understand about how they see the world. So I think that listening to each other is something which I'm continually asking my colleagues to do and to do myself. One of the things about the Trust in Health Inequalities is that we've now, indeed the NHS, it is now a formal part of our strategy. So the board approved our strategy for health inequalities, and Catherine McDermott is the director who leads on our behalf, who you may know or come to know, to formulate a strategy as to how we really go from well-intentioned engagement to a more joined up and meaningful, purposeful engagement. And so hopefully you'll see that coming to fruition. And the board of the trust, which I chair, regularly reviews the progress on that. One of the things that we discovered is that the data we have is not as good as we would like it to be. That is, in terms of the background of different people, their ethnicity, etc. And so we've got a major program to make sure that the data we collect has that data available, so we can start to understand better the different inequalities that are seen by different communities. One aspect which is particularly interesting to me, as I'm also a carer for someone with a mental health problem, is understanding some of the mental health issues relating to minority communities. And we know the evidence is that, for example, that people from a Black ethnic background are more likely to be placed under Section of the Mental Health Act than those from a white background. I'm working with our medical director, Minu Irani, to try and understand, is there good evidence there as to explain why this might happen? In fact, I just had an email from him this morning with an article from The Lancet, which is the medical journal, reviewing a whole range of evidence. And there doesn't seem to be a clarity yet about why that cause is there. But this is the sort of thing we need to understand, because if we can understand that, we can start to put in place actions to address it. Going back to the engagement of the communities and Victor's point, I'm totally with Victor on this. We need to find a way to not just do it on a sort of here and there basis, but a consistent basis across not only, of course, West Berkshire and Reading is important, but also Slough is an important area for us with a very strong Asian population. How to engage, what groups are the way to engage, where will people feel comfortable about receiving information and giving information, where they might feel that, from something like the NHS or indeed other government organisations, it might seem too difficult. So we're very keen to understand this process and to build on that. I also recognise, I think it was the lady, My Voice in Power lady, who was speaking about how difficult it is if you're not inside the system to understand how the system works. It can seem very disjoint and very fragmented. And I'm particularly interested in seeing how, through the new integrated care systems that are being put in place, which includes West Berkshire and indeed East Berkshire, and separate systems, but the philosophy is the same, how we can bring together the local authorities and the other public services with health more closely and more in one sort of way, so that people don't have to worry about are they going here or there for for advice. And I think that'll take a bit of time, but everyone wants to make it work. Finally, if I may, Cicely, just to say that the board of the trust is appointed by public governors. Indeed, we have Paul Myers-Coase on the call today as one of our governors. And I would encourage all of you, if you're interested in being able to influence the direction of Berkshire Healthcare, for example, to consider firstly becoming a member of the trust. It's completely free, there's no obligation, but it gives you more access. And also perhaps to think about standing as a governor for the trust. Now, governors don't run the trust day to day, it's the board that runs the trust, but the governors do appoint the members of the board. So you can make sure that we're doing the right things for the communities as a whole. So if you're interested, either contact Cicely or you can contact me directly. You can get my email off our website, and I'll be very happy to talk to anyone who's interested. So we're very committed. I have a personal interest as well, which makes it somehow more real for me. And I do recognise the things you're saying, and I welcome the support that people like Victor and Acre Reading are doing. And we just want to work out how to do more of that. So I think I'll stop there before I talk too much. But Cicely, thank you very much.
Thank you, Martin, as always. And as communities, we always want more because we want to make the biggest difference we can with the assets we perhaps naturally have. Esther, over to you.
Thank you so much, Cicely. Next, our speaker. I just want to introduce our next speaker, and that is Joanne Mciwen, who is Public Health Development Manager, Thames Valley. She has been working with about 40 researchers in the Southeast region. And in Reading, we had a partnership of University of Reading, the Council, Acre, Reading Voluntary Action, Reading Community Learning Center. There was another research with Utulifu, and then another research with Chakwa Foundation. These researches have just come to the end and the reports are being wrapped up. So there's more evidence of the data because the research was focusing on health inequalities among the Black ethnic minority and how COVID has kind of widened that. I'm happy to introduce Joanne, just to give us the experience of how they have engaged with the community because they used the local community members. And I'm happy just to say, Eva is here, a researcher, Tariq is here, and many more who have done that research. Joanne, it's your time. If you can share the experience, please. Thank you.
Can you hear me now?
Yes, we can.
You can. Okay, then, and you can see me as well.
Yeah.
Okay, great. So thanks, Esther, for that introduction. That's very kind of you. It's really lovely to be able to speak to you all today, just for a few minutes. You've got so much to share with each other, so I don't want to kind of bog you down with all the kind of the NHS part of things, and I'm sure there's so much more to learn from the communities here, and that's really what we wanted to do. So at Health Education England, it's a long-armed NHS institution, and quite soon actually we will be becoming part of NHS England, so there's all change afoot for us. But what we do is we commission health training for our workforce in health, and it is a very NHS focus, very health focus, but I work in the public health team, and this is about the training and education and CPD for a public health workforce, not just the core workforce, which is your practitioners and your specialty registrars, but also for that wider workforce, and that's for those who work in communities, a broader picture of those who have a public health role. And so what we wanted to do is we wanted to reach out to community organisations, those who are really rooted within their communities, and train them around how to do research, how to make that research actionable, and how to be able to engage with strategic stakeholders to get the findings from the research with some results in place. And so it came out of the COVID-19 report the PHE produced called Beyond the Data, Understanding the Effect of COVID-19 on Black, Asian and minority ethnic communities. And there was a recommendation there, recommendation number 2, and that was to work with communities in research where the community researchers are equal partners with all the strategic organisations. So that's what we set out to do at Health Education England. Working with Esther has been really, really exciting for us. Esther has been really key in bringing in all these small organisations together. And when I say small, it's small because in the scheme of the NHS, so having that kind of connection there. So we work quite closely with Esther and other leads of organisations as well, so that we can make sure that we are flexible enough to hear what the needs of the researchers are. Listen to them, set up forums where they can talk with us and tell us what sort of needs that they have specific to the research when they're going back to the communities. One of the things that we wanted to do was to ensure that the communities had a voice in what was being researched. So we didn't set any agenda out other than that it had to be around the effect of COVID-19, but that's a really broad canvas, isn't it? And so the researchers went back to their communities and asked them, what is important to you? What has affected you? What do you want to see a change in? And they come back with that. And you've got, for example, Tarek here, who's done quite a lot on men's mental health, a subject that isn't often spoken about. So that was really, this was the impetus of this community participatory action research. One of the things we tried to do was kind of we took a lot of the kind of feedback from the leads and feedback from that came from the researchers as well to the steering group to allow kind of like to translate it into actionable tasks for us, so that we try to connect with these, the new ICSs, integrated care systems, with the local authorities, with NHS trusts and so on. And so, we understand that long-armed institutions like the Health Education England and NHS England and Public Health England, as it was, can be quite distant and quite hands-off, and so this was an opportunity for us to be a bit more approachable, and so that whatever we did didn't kind of like, we wanted to have a kind of connection with the researchers and their leads, where we allow kind of them to engage in the process. We listen and flexible, but at the same time that our presence doesn't overshadow the researchers as well, so they're not too worried that the commissioners are there and they're watching what we're doing. So we kind of give them that freedom, and that we're not kind of like gatekeepers looking over their shoulders about what they're doing. And so we also encourage the leads, like the likes of Esther and so on, to feedback with us and express the views of the researchers. So we're really excited that this project is about to finish. A lot of the researchers have done their work, particularly in Reading. They've been absolutely fantastic, and we're really looking forward to seeing what their final pieces of work are. There's a lot of learning for us at Health Education England and our partners. So when I mentioned Public Health England, we partnered with Public Health England at the time, but they are now divided into the Office for Health Improvement and Disparities. It's now under the Department of Health, and also NHS England. So we work closely with them. So there's a lot of learning for us, and we are evaluating that. We've been we've been shifting, we've been quite agile throughout this process, but we'll continue to do that, and we'll evaluate the programme completely. And with that, we hope to run it again with all the learning that we've had over the past year. And we are finishing this piece of work where we're going to have a celebration event on the 10th, the 10th, 11th, and the 12th of May, 3 mornings, where we will showcase the researchers' work, where they will come online at a kind of online conference type thing, and they'll talk about what they've studied, what they've found, how they've found engaging with communities, with their communities, and what the communities want. So it's a real opportunity to celebrate the researchers for the work that they've done. It's good learning for them as well when they sit and they share with others. We will have strategic partners on this conference, so they'll be able to hear what's happening, even though we're kind of like communicating them outside of this and trying to communicate and trying to get responses and things, but that's an opportunity there. And so it'll be a great if you as a group would like to attend that session. As I say, the 3 mornings, you don't have to attend all of them. The first day will be about inclusion, the second day will be about mental health, and the third day will be about health services, and we might focus more on cardiovascular diseases and cancers. And so, you know, I'm putting Esther in the spot here. Esther, you can be the link to your team here today to this particular event, and we'd love to have you on board and attending that session.
Thank you so much, Joanne, for that 10th, 11th, and May event. We will be able to share the link for you to register, and everyone and anybody is welcome to attend. Back to you, Cicely. Thank you so much, Joanne.
Thank you. Very, very informative things there going on for us. So the ball is on our side. And now to hear from Kama from the NHS, doing quite a lot of work with a lot of influence and experience on community engagement. So Kama, over to you.
Thank you, Cecily. So if you don't mind, if we can share the slides.
Yeah.
No?
I'll do that. All right. Okay. Oops. Right. Okay.
Thank you. So Cecily asked if I could come and talk to you about working together on, well, about meaningful engagement to try and reduce health inequalities. And it's something that I know a lot of us have got a lot of passion to try and achieve. And I think the first thing I thought was it is about working together. And without working together, you won't have meaningful engagement. And I think a lot of people have already talked about where do you go, how do you start? And so most of these things have been discussed already. But it is talking to people who have those connections, who are able to help direct how you're engaging and who you're talking to. And also it can go both ways. It can go from the community saying, actually, this is something that is an issue for us. Can we have a look at different ways of dealing with it? Next slide, please. So I've just put a definition of what is engagement. And to me, I think it's about involvement. I think it's about listening. I think it's about interacting and trying to collaborate together. And I think you have to just keep trying, really, because you never get it right and you never finish it. Next slide, please. This was from National Voices, and it was talking about the 6 principles for engaging people and communities. I thought it was quite a good infographic. I'm not sure it covers everything, but for reference, I thought I will share that with everybody. Next slide, please. So as I've said already, to me, meaningful engagement means listening. It means involving and, if possible, co-producing services. A lot of people talk about co-production when they don't actually mean co-production, but to me, it's about influencing how that service is designed, delivered, modified, or changed in any way. Next one, please. I'm going to skip these ones, Cecily, but this is just giving useful background about where did it come from in terms of from an NHS point of view. How did it start, and why did we start thinking about engagement formally? So if you want any background, it's all here. But I won't go through it. I would recommend, if you get a moment, it's an old clip, but there's a clip to a King's Fund video there, and it just explains how the NHS works and how it can be influenced. And some of the things I talked about is things that we've done over the time. How have we tried to interact and make sure that we're working together? And it's through the health and well-being boards that I think we've got an opportunity. Next one, please. So I think key responsibilities are looking at reducing health inequalities, improving outcomes, making sure we've got value for money, and wider social and economic development for the health and well-being boards. And the group that I worked with, we had a large interaction with lots of different people, and these are just a few of the organizations that we worked together with. Next slide, thank you. And so I think our motto was the 3 C's: collaborate, cooperate, and co-produce, if we could. Next one, please. And I think that the thing that I liked was having our conference, which was in public. We carried on holding it during COVID, and it was an annual event. And it was as much as putting patients and citizens together as it was for the professionals to network with one another, because in your day job, you don't necessarily have the opportunity to hear from others and how they're working with the same community. COVID, the new C word, lots of good work happening, lots and lots of good work. I don't need to tell you all. These are just 4 examples that I was involved in. And I think that reminded us that we can work together. And when we put our minds to it, we work together really, really well. Next slide, please. So I think if we're looking as a system, what can we do? And when I'm saying system, I think this is wider than one group. I think this is lots of groups working together. Obviously, we have the recovery after COVID. We're all looking together about addressing inequalities. I think there's a common goal of trying to improve services to residents. But I think the bit that we're not doing yet is acting and behaving as a system so we can influence over a wider footprint. Next one. So back to today. What are we here for? We're looking at health inequalities and how we can reduce the gap. So, as I said, building on the good work that we've had, we've got massive waiting lists in the NHS, and we need to be trying to recover those services and to ensure that there isn't delay to anybody needing treatment. But as well as that, we have to look at improving health outcomes and reducing health inequalities. Some of the things that can help, making sure we've got connections. That could be through digital. It could be about having the right data and information that gives you the idea as to where to start. It could be the people, making sure you've got adequate resources and that you're working together. It could be about innovation, but it's definitely always about improvement. Challenges and barriers. there could be personal factors why individuals can't access services. There could be social and cultural ones. Knowledge and awareness, I think, goes for everybody. The services are changing all the time. How are you meant to stay on top of knowing how to access them and how to sort of reach it in the best way? And I always give the example, I'm a child of the 60s, late 60s. And growing up, we had public service announcements, I think they were called. And so you had one for the Green Cross Code, you had one about how to use seatbelts, and the seatbelt one still stays in my mind, clunk, click on every trip. And I just think we need very simple, short things that are nationally done that bring us all together. But there is a resistance nationally to try and communicate on these things, and they keep leaving it to local systems. So I'll leave that with you. I am still pushing the national guys, though, to say, come on, you've got the resources and the expertise, help us. And I think experiences and expectations sometimes don't always deliver what they should be. Next slide. We've talked about those who are most likely to face barriers. These are just a few of the groups that I've worked with in the past. Next slide. And why do it? I think we know we have to. And I think the gap is widening with health inequalities. I think inclusion is so important on every level. And then I think trying to support individuals and the general public on how to access service is really, really, really critical. And I think if we can do that together, it would be helpful. That's it. Thank you. Any questions? No? Oh, Alice. Yeah.
Kamal, I mean, we talked about integration. Can you hear me? Can you talk about integration and all? How, NHS England is doing a big project at the moment called Core 20+4. I mean, they're doing all that, but they are not. Now, how that information is not disseminated to the community and working together. I mean, they've identified based on research. How is that? How? What are we going to do to disseminate it to the community? How can we?
So, Alice, just for your benefit, so I'm working with the NHS England regional offices now, and I've seen the Core 20 Plus coming through. I think the first instance is to try and activate the integrated care systems, or ICBs as they will be called, because the responsibility will lie with them to organise how they're going to tackle health inequalities and how they're going to be doing that together. I know there is a board already for Bob, which is our system, Buckinghamshire, Oxfordshire, and Berkshire West, but I'm not involved with those individuals anymore. But I'm happy to pick up outside if you want to have any further discussion, no problem.
Thank you for that.
Thank
Any more
you.
questions for Kamal?
Yes.
Yes, Mohammed.
Yeah, what are the three qualities of health inequality?
Sorry,
what are the three categories of health inequality?
What are the two?
Three categories of health inequality.
In terms of?
Social, economical, environment, and inadequacy.
Yeah.
That's the answer.
Okay.
These are all barriers.
Yes, they are. Yeah.
Thank you for that, Mohammed. Thank you. So thank you for that, Kamal. And yes, thank you. We need to work together to make our health all better and improve our communities. Thank you for that. I'm going to invite Amanda from RBC. Who is going to be talking about the Reading strategy? Amanda, got 5 to 6 minutes to give us a presentation.
Yes, afternoon everyone. Apologies for the poor video and audio. I'm in an area with very poor network. I was hoping to share a presentation, but I'll just speak on it, seeing as there's not a lot of time. But as Eva said, I'll be just updating everyone on the work in relation to the Berkshire West Joint Health and Wellbeing Strategy, as well as the implementation plans that are associated to that strategy. So for those that may not be aware, it's been quite a long journey in the development of the strategy. And I've shared the presentation with Cecily just so that can be circulated if people wanted it. But we worked together across Berkshire West, so this included Wokingham, Reading, and West Berkshire to develop this joint health and wellbeing strategy. It was finally approved in March 2021, and the process that we've been going through to date is around delivering what we call the implementation plans or the action plans that will enable us to start to take actions that will initiate change in order for us to see the vision that we want to see at the end of the strategy. So, we've already touched on various determinants of health, that can involve the working environment, that can look at education, unemployment, housing. There are various factors that can influence or contribute to poor health and widen inequalities gaps. So with regards to the strategy, there's been almost endless engagement work that has taken place throughout the process of developing the strategy as well as the plans. And eventually the strategy priorities were narrowed down to 5 areas. So these areas, just going to list them for everyone. So the first very much focuses on health inequalities, although health inequalities is a key theme across all 5 priorities. The first is around reducing the differences in health between different groups of people. The second priority is focused around supporting individuals at high risk of bad health outcomes to live healthy lives. Priority 3 is around helping children and families in early years. 4 is around promoting good mental health and well-being for all children and young people. And 5 is around promoting good mental health and well-being for all adults. So as I mentioned before, this strategy is a Berkshire West joint strategy. However, each local authority is developing their own, locally tailored implementation plans, because we know that there might be varying needs across the different local authorities. But we also do have there might be some commonalities. So something that's very key in making sure that we achieve the vision that we're aiming to achieve as part of this strategy is that something that Kamal brought up earlier as well is around a whole systems approach to tackling inequalities. It's not one organization that can do it. It's not just the NHS. It's not just, local authorities. Everyone has a role to play, and hence it is about a whole systems approach. And how can we all come together, put our resources together, put our knowledge together, our insights to ensure that we are delivering aligned actions wherever possible. So with regards to the implementation plans, the current plans are for a 3-year period, although the strategy is for a 10-year period. And the reason for this is that these implementation plans will be working documents that will adapt to respond to local need. So as we gather more insights, as we work with more people, more organizations, we will be adapting and updating the implementation plans to ensure that no matter what changes are happening, they are also following the changes and making sure that we continue to meet people's needs. Just finally, I just wanted to highlight that there are a range of groups, as well as residents that have been engaged with throughout the process, including various, the Mental Wellbeing Group, the Reading Integration Board, Brighter Futures for Children, a range of different organizations. The list is endless. And where we are now is a very critical point where we were, as I said, we're developing our implementation plans. So if there are if there's anyone in this conference today that feels like actually they can contribute in one way or another to those 5 priorities mentioned, we would love to hear from you, because as I said before, this is about working together and aligning actions in order to tackle the issue of health inequalities. So thank you. Happy to take any questions.
Amanda, I'm Alice from Community United. Just to share with you that we've had loads of strategies for so many years, and the themes have been the same. What is the difference from now? And also, there's got to be a cutting point of, we have not seen from the last strategy what was achieved and not achieved, and we've got another strategy here. And I just feel that we are just going round and round and round and round. There's not an end point. I appreciate that there is this 3-year kind of, but that what we have not measured the outcome. What has been good? What has been bad? Because they are all similar themes coming back. So just what is different?
So
that is my question.
Yeah. So to answer your question, the issue of health inequalities has been around for decades and decades, and it continues to be a priority because it continues to be an issue. It's a grave issue, and that's why you'll find that some of the themes are very common. So in terms of the previous strategy, the reporting or the monitoring process was to provide updates at the Health and Wellbeing Board at various meetings on a quarterly basis on the progress of the implementation plans. So there are various groups which, again, are listed, I'll share with Cecily, where people leading on the actions, including people supporting that, will be providing updates. So there is a method in order to monitor progress of the actions that we're implementing. Thankfully, it's not something that's just created and then just left alone. There is always action happening. But I do think there needs to be a mechanism that ensures that all relevant people are aware of the progress that's being made. Obviously, the reports that come about from the Health and Wellbeing Board are publicly available and anyone can access those. And as I said before, on a quarterly basis, the progress that will be being made will be reported on there, including a dashboard which shows how we're performing according to our targets, but also a narrative report, which is looking more on the qualitative side, on the what's happening and how are we progressing, rather than just numbers. So there is some work that will be taking place to ensure that people are updated of the progress.
But this has been for a while, though. This is where the frustration, because we are going back to the community asking the same question, going, after a while, the community is not going to engage. And, how do you plan to keep the momentum going? Because nothing has changed. The well-being of the community has not changed. What evidence have you got? Because we are going back to the same theme. This is where the frustration comes. I mean, I've seen 7 reports of health inequalities for years.
Yes.
Same theme. Nothing has changed.
So I understand your frustration, but it's not for me as an individual to say what will change or what has changed. Because as I said before, and something that Kamal mentioned, it's about a whole systems approach. It's not something that can change overnight. And a lot of the indicators, a lot of the things that we're looking to see change in don't change in a short span of time at all. And it's something that will take consistent effort in order for us to see a long-term result. But unfortunately, I understand your frustration, and even myself as a someone who falls into the seldomly heard groups and is likely to experience some kind of health inequalities, it's something that we need to continue working on. That's all we can do, to continue working on it and consider new approaches, so that we're not just, what do they say about a fool is someone who repeats the same action and expects a different result. So we also need to be approaching the situation in a different manner in order to see different results.
Thank you for that. I can see Alice's hand. Well, Councillor Alice.
Hi, good afternoon, everybody. I just wanted to have a reflection on some of these things that have been discussed on the forum, specifically about mental health, and trying to figure out the way we also use terminologies when we discuss things with people with mental health, or generally with Black and Asian minorities. if we look at generally what has happened is that even when I used to work as a mental health social worker almost 10 years ago, there isn't much that has changed. Black men are 4 times more likely to be detained under Mental Health Act. Older Asian women are at risk of suicide. Refugees and asylum seekers generally have mental health and post-traumatic things, and we have so many refugees now in this country, some who are coming from Ukraine. And I really wanted to step back and reflect, not in my capacity as a counselor or anybody, but as a person who lives in Reading and has worked with different organizations in the community, and start to think on what is it that we are missing, because the surveys, of them, I can't even, as much as I'm an academic, I can't even read without Googling them, that are produced to understand about mental health. And those terminologies are quite difficult. I remember yesterday with my sister Esther, who is here, when we were at the Broad Street Mall. One of the things we discussed again was terminology. And difficult to reach is you find in every academic article or in every NHS thing. And we said, difficult to reach, some of the people are here. Have you ever asked them that are they difficult to actually reach and talk to them? Or are you speaking the language that they don't understand, most of them? Because the communities that are difficult to reach or deprived communities, on its own, it's a stigma, as you say. So these deprived communities, these difficult to reach communities, which are in all these documents that are produced, surveys continuously being produced every now and again to find out what is the problem. But the problem has been known for 20 years, for 10 years, for the past 5 years. And again, we're still going on producing papers to look at health inequalities. When you look at it, when I was working as a social worker, the highest people that were affected were in the Black communities, and then the Asian women also on suicide, and young people, young Black people, we seem to miss them along the line, and they are very much affected. There's a high suicide going on with young people, Black young people. And the strategies, some of them, is to ask them what they need, because most of the strategies that are done is about what the expertise think works for the people, instead of using the simplicity kind of things we discussed even yesterday, simple things that can work for people. For example, music. Music is high on young people. It helps them with their mental health, how they access small legal things that they can do in local areas, how they can access for older people just a bench to sit and talk to somebody, legal things like that, which doesn't cost a lot of money for so many of the NHS provisions or service providers. But we need to really reflect on the language and how we strategize things. And we can't continue having meetings and strategies and trying to do things for people when people can actually be able to participate and do things for themselves. And I think Esther mentioned something, that these people that we approach sometimes have solutions to the things that we are discussing. And that solution is actually probably sometimes not the medication, it's actually preventative measures that we do in the beginning before things get in the beginning, identifying those things in the beginning when we try. I know that a lot of other psychiatrists and academics write papers like they've been done this, but it produces money for those that do that. But in really terms, the things that happening to people are the local communities, the voluntary sector, the small groups, community groups, some of them that are not even registered, that are taking the burden of understanding people that they live with in the community. And those are the people that need to be understood, and you need to access them and speak to them, and so that you are aware of what is happening with people and how people can help with this is quite important. We need to have a conversations about how we make language and strategies that suit people, because I really want to hear from the speakers what has changed. Because for me, if we continue channeling these strategies without looking at the gap of what has changed, why now? Why not 10 years ago? Why, what has really happened within the part of this? And the language is very important, how we relate to other people, because most of it is important how we speak to people and see that. Thank you.
Thank you for that, Alice. I'll just bring in Amanda for quick feedback on, I see your hand up, and then after that we'll have Simran, please. Thank you.
Yes, I was just going to say, in relation specifically to the health and well-being strategy, we are working closely with voluntary and community sector, with service users and residents, and hopefully you've had an opportunity to read the strategy, and actually the language used, particularly to that in that one, is hopefully quite universal and easy to understand. But I do agree that there's a lot of jargon used in some in a range of documents, which in itself can be a barrier. We are, we've been doing some work with ESTA, the CPA work, and where we can, trying to link it into ongoing work that we're delivering. I think there is this acknowledgement that we need to start approaching things differently, but not only going to seek out insights from communities, and then when we need them again, go and seek more insights, and then we just go quiet. But actually, we need to complete the circle. Once we've, going back and actually sharing how have we used the insights that we've obtained, what has it fed into, and what difference is it making, and making sure that everyone, it's an inclusive approach rather than a down up approach. So I just wanted to say that, I can't answer the question of exactly what has changed, because that's part of the process of the strategy, looking at, what has changed, what do we need to do differently, and how do we approach it. But the thing that I did want to emphasize is this strong need for a whole systems approach, a strong need for collaborative working and co-production, but also the strong need to ensure that we're completing the circle and going back to the people that have actually given us those insights, so that they know how they've been used. So I just wanted to add that. But if anyone has any further questions before I leave the meeting, please do let me know.
Thank you.
But I also, just a quick one to add, not specifically, this question was not specifically about I've read the strategy from the council as a councillor. I'm just talking holistically about the NHS doesn't have money for mental health nurses, and we are busy producing strategies. By bringing that into perspective and actually finding the things to help in communities and bringing things to the local communities. How are we going to do that if there is not enough staff to actually prevent those other things? There's a waiting list for children in mental health, which the NHS cannot actually accommodate, or young people, which goes up to about 1.5 years. I've got people that have been waiting for 1.5 years, and the mental health has gone up. But these are the things that we need to find out how we prevent from the beginning. If we have enough staff to come to the local community, for example, a community center, once a week, and a mental health nurse comes in, people pop around and say, I'm not feeling well, this is happening to me, I don't understand what is happening. This can help in so many legal ways. And then they are referred to some legal other things, voluntary sectors. We've got a big database of voluntary sector, and that can be very, very helpful.
Thank you for that, Alice. Yes, I'm sure Amanda's going to take some of those things on board, and everybody else on here, and we can get those done. Just for the sake of time, I'm going to bring in Simran, and after Simran, we're going to have Tariq, one of our CPA researchers as well. So just a few more minutes, and then we should be done. But very good discussion and good feedback. Simran?
Yes. Hello. Hello. Can you hear me now?
I can. Yes, I can.
Excellent, excellent. Hello, everyone. Thanks, Cicely, for inviting me here. Good discussion, everyone, going on. I am actually the chair yoga instructor, seated exercises instructor for Cicely, and taking the session for Reading Community Learning Center. There we are taking care of Pakistani Community Center ladies. So I'm taking weekly one session for our CLC and one for Cicely on every Wednesday, 11 to 12. I'm experienced and trained yoga instructor. Basically, I am doing the chair yoga, seated exercises. I'm having multiple sclerosis. Last August, during the relapse, I was on wheelchair, and Cicely and all the participants request that I should continue with the exercises with them. Although lower body I cannot move, upper body we did. And thanks every participant and everyone. They keep me mentally, up high, that yes, I can do something for myself and for them in that condition as well. So that is very good for your well-being when others are there for you, when others are, accepting you the way you are. They are not judging you that, oh, what you can do on wheelchair, how you can teach us on wheelchair. But yes, they said you keep on going, but now thankfully I'm not on wheelchair. Now I'm better than that. But still, that is why I'll say the physical exercises or any kind of, even the exercise or the meeting one-to-one, even on Zoom, will give you the your mental well-being high. You are feeling positive. You are feeling that yes, people are there for you. You are not alone, and you are not the only one who is suffering, or these kind of things. So my chair yoga Zoom link you will get from Cicely for every Wednesday session. And if you want to have my contact number, that will also you get from Cicely. Cicely, please share my telephone, mobile number with everyone. I don't mind if you need any assistance, any help. And if you are thinking that I can help your community in any way, please do let me inform or do let me know that yes, I can do anything for you people. I will be very privileged and happy to do that. There are many benefits of the physical exercises. You all are aware of it. So there is no need that I will keep on sharing the benefits of exercises. The physical benefits are too much, but what we are ignoring is the mental benefits. After the exercises, the happy hormone which our body will release will keep your mental well-being high, will keep your mental well-being positive, which is very important during this COVID time when we need to connect with each other, but we can't. This is very important. At least not if we can't connect face to face. By Zoom, we can do that. And the same benefit we are getting by Zoom as well. Yeah, we can't hug each other, but that's not the issue. We are doing the self-hug after every session. We hug ourselves and connect with ourselves, love ourselves, and feel that loving connection with ourselves, which is very important. So I will say everyone should try once to know what are the benefits of the exercises for your physical as well as your mental well-being. All these hormones which we are releasing during the exercise when we are focusing or having our, breathing. Why I call it chair yoga? Why not the chair exercises? Because we are focusing on our breathing, inhalation, exhalation. And for that 1 hour, we are connecting with our own self. So after that 1 hour session, we feel that we have done something for our own self. We have given 100% to our own self rather than anyone else around. So when we are happy with our own self, that happiness we will spread around others. After the session, you will get to know when you are connect with yourself. So I will highly recommend if you are experiencing or having anyone around you, you are feeling that, okay, not mentally well-being or not, energetic or positive or any kind of not in the natural state of mind, please, please, please do tell them that connect with us through Zoom, one session only. After the one session, they will get to know the difference in their physical body as well as their mind. They will feel happy, they will feel positive, they will think a different perspective they are having for their own self rather than only thinking in, when we are thinking negative or low about ourselves, then that loop is keep on going and we are thinking in that way only, no other way around. So it's very important that time you should have someone to connect with so that you can share what's going on with you. And when the other party is listening to you, other people are listening to you, or maybe they will give you some other direction or view to deal with that issue, to deal with that problem, you will get to know, yes, there are other ways also to think about that particular situation or the problem which you are having. So it's very, very important, I will say. And it's not matter, in the very first session, people were thinking, oh, what we can do on chair. Is it? We are sitting on a chair or we can do something for ourselves? I don't think so. Okay, give it a try. And after the session, you will realize many things you can do for your body. You can stretch, you can bend, you can twist, you can do wonderful things for yourself sitting on a chair. Even if when you are working in an office, you don't have 1 hour for yourself. Even 5-10 minutes are sufficient during your lunchtime, during your tea break, during your coffee break. Stretch your body. You will feel wonderful. You will feel amazing. And that, obviously, when you are feeling good about yourself, you are going to share good with others. You are doing good for others. So it's very, very important to look after yourself first and then look after others around you. So the rule of our human body is use it or lose it. If we are not using our body, eventually we are losing it. My MS nurse was telling me when I was on wheelchair, Simran, keep on moving, otherwise your legs are going to, eventually give up and you are not going to walk. And I said, oh, is it so? I can't walk? How I can think that I can't walk? I'm having so many positive people around me. They all are praying for me. They all are sending good wishes to me as a, instructor, and they don't want to see me on wheelchair. Definitely I will improve, maybe not now. And time is going to change. Things are going to change with time. We should have that patience that yes, things are not going to remain like this forever. They are going to change. Maybe it will take time, maybe a little longer than what we are expecting, but these are going to change. So never ever lose hope. Never ever think that you are stuck in some situation and this is not going to change. No, I don't know. It's my personal experience now. So I keep on talking about this as long as I want.
Thank you, Simran. We can see how passionate you were about it. Yeah, definitely. And yes, on Wednesday, seated access is a good activity.
Yes.
Put your number on the system, but thank you for that. And hopefully most people can join and get to feel good about themselves. Thank you very much, Simran.
Thank you very much. Thank you for having me.
Thank you. And I'll bring in Tariq now just to share with us. Thank you.
Thank you.
Hello, hi, good afternoon, everyone.
Good afternoon, Tariq.
Hello, hi, thanks, Eva, for giving me this chance to talk. Yeah, health, the inequality of health is existing in broad way. And I'm fortunate that I'm one of the people who have done the CEPA research on men and mental health, especially on men from BME communities. And during my research, I came through a report from England Health and Equality England. Is it might be a bit back between 2014-16, but it was shocking that the life expectancy in deprived areas in England is 9.3 for men and 7.3 for women. And that is a big gap number. And this gap shouldn't be existed in a modern society like England. And health and equality in health is one of the many inequalities has to be addressed and checked. But it's not been actually up to now, nothing have been done. And in my research about men and mental health, I came across a lot of things. And one of the things that we ask men during the research is a lot of things about accessing mental health and the barriers and services they can get. And really, we found out that people are very naive and very simply don't know what is even mental health and how do they access mental health and what the services can get it from mental health and who is going to serve them. And even if there's any help they can get, mostly are online services. And online services, a lot of barriers connecting people to them, like language barriers. And people are not many of them are not familiar with computers and smartphone to connect with services. And that's even reduce or increase the gap of accessing mental health services. So it's really shocking that, and we are in modern society, we are facing through these highly things. A while back, during our research, we had a meeting with a group of university researchers who are trying to access communities to find out how to help communities. And these young boys as well, they try to get into deprived areas and make meetings and know what is gonna help them and what services do they want. And one of them is health services. And health service is a right for everyone, and fair access to health is important for everyone. Especially in my perspective, mental health is BME communities are so deprived from mental health, and they when we ask them some question about what does it stop you from getting into mental health service if you need, some answers are coming. It's very long appointments. There's no mental health services to access, and fewer psychiatric doctors and clinics. And these things shouldn't be difficult to provide, because to have a healthy and productive community and society, you have to provide health to people to be productive. But ignoring simple things like mental health, it can lead into disasters, because there's a lot of misconceptions and stereotypes when it comes to mental health around Black and minority communities. Because when they think that you are a mental health patient, they think that you are always aggressive and violent, and they have to restrain you and put you somewhere in a psychiatric hospital, which is more or less like a detention. And these things can be very easily avoidable by preventing mental health from the beginning. When there is small symptoms and triggers, you see them. If you provide good mental health, you can cure these triggers, and you can have a healthy society rather than wait for consequences. And we already have a lot of examples of these things. So we have Aubrey Park incidents. They led the young guy with the mental health to be there among people without noticing, and let them progress. And when things happen, they say things happen because of so and so. And it's happened because this guy is not being looked after while he's going through a mental health. We have the same incident happen in Glasgow in 20 when a mental health patient from Sudanese community was put in a hotel, and he was going through a bad mental health period, and he wasn't looked after until a disaster happened, and he stopped people, and then they tried to find a solution, and this solution, this should be preventable before disasters happen. We have a lot of young boys from BME communities get into drinking and drugs because they are going through mental health, nobody looking after them. We have people going through suicides, a lot of people going through a poverty because they cannot get jobs because the misconception and the stigma of mental health that do not allow them to access into job opportunities. And all of these things should be done. And I think a lot of research has been done before, and a lot of them is very well known to the authorities, but the delay and the cut in funding is stopping people from giving services and reducing the gap from 9.3. I think it might be reduced now. I don't know. I haven't seen the latest report, but 9.3 years just for somebody living in a privileged area and someone living in unprivileged area is unacceptable. I can say that maybe between Africa and Europe, there's a gap because a lack of services. But if in England, we see this gap in just between two areas, few miles between them is unacceptable. And I think government and charities, it's as Esther said, it can't be difficult to get into communities. Communities are there waiting for you to reach them. The communities has to be, it's very easy to access. When I've been asked to join the CIPA research and I connect, I didn't just, they're in front of me, I just talk to anyone from my community, and I found out that they know nothing about these services. They know nothing about health. They know nothing about mental health. So there should be a lot of effort to be done to get into these communities, and communities has to be empowered and given voice to talk about. If you restrain community and do not give them voice to talk, they never reach you. They never give you a chance to say what you want to say, because I think there's a lot of restraint in community voices. Our voices do not go high because it's blocked somewhere in somehow. And that barriers should be broken. They should allow communities to say what they want to say, and the government should make more effort to get into communities, not waiting for the communities to get into the government. Because I will, in my conclusion of my speech, I will conclude with some examples of this Sudanese refugees, because if the authorities open their door to the local communities and allow them to get in and talk about, people will go and talk about. If they give them that assurance and they give them that respect to raise their issues, they will raise it. But if they deprive them, they were not born deprived. I think somehow they have been deprived by systematic racism. Because if you put all poor people in one area and reduce their services, do not expect them to be a scientist, or do not expect them to be very intelligent people. So sorry if you're saying intelligent, but do not expect them to give much, because they don't get much from you to give you what they want to give. And as I said, I'm going to conclude my speech from the refugees who have been brought to Reading in a lot of compound. It might not be directly connected to the subject of health, but indirectly it's connected, because these young people, there are hundreds of them in 3 or 4 compounds in Reading. And if you don't provide them, a lot of them, they're going through a lot of mental health problems. They are going through a lot of health issues. Some of them, they need heart operations. Some of them, they go across a lot of countries and deserts and water and things to get here, and they've been placed. So they're going through a lot of things in their mind. If you don't treat them now and check them and find out what do they make them feel not better, uh, if you waited until something happened, because they came from different cultures, they don't know how to access mental health services. They don't know even something called GP. I'm glad that James and Eka, they appoint some of them to refugee support groups. They register them to work health center in town center to have some treatments. So these things, and a lot of them now are getting better in their mental status. Thank you, Eva, who are providing them with Tuesday hub sessions in Eka Center, and they're getting better. They're positively, they're getting better. But these young people, unless they get treated, they look after and given assurance and help. If we let them just hanging around, there's a lot of young girls in IBS Hotel along Oxford Road. They're from Eritrea, Ethiopia, Afghanistan. They don't know anything. These girls are very easy to grab by prostitution or by traffickers or by anything. This unless the society look after them, they might be turned into a wrong direction, and they might be a bad thing for society, because now they're in England, they are a part of society. They should be integrated into the society. They should be taught and they should be offered help, not let wandering around, don't know what to do. And hopefully, probably the time is running out. We can talk a lot, but that's just simple thing I want to say. And thank you, everyone.
Thank you very much, Tariq. Tariq is one of our community champions. And yes, I'm sure a lot of people will be looking forward to hear your research and read about it. And hopefully on the back of that, we have enough data to make a change. And again, your plea again for the refugees that we've got in Reading community, we can get a space to get to make them their well-being a bit better. Thank you very much for that, Tariq. Got any questions for Tariq, please put in the chat, but thank you for that. I'm going to bring in Nisha. Thank you all for your patience. It's going to be our last speaker, and then James briefly, and then we're about to be done. Nisha, just 3 minutes about what you're doing.
Oh, thank you, Eva. Thank you so much. Thank you, Cecily, for giving this opportunity to me as well. And there are so many things, as you said, like it's, first of all, introduce myself. My name is Nisa, working for Macmillan Cancer Education Project in Berkshire West for CCG. And working since 2017. And one of the main objective is to help and support to improve the health inequalities in getting access to the cancer services among the seldom heard groups, including BAME communities. So I work with, in that sense, my role is to work with the communities and also with the service providers, so kind of bridging the gap between the communities and the service providers. So because as we already heard many things about the communities, like the barriers, and because one of the main other activities to achieve those goals is like prevention and early diagnosis of the cancer. So how we can do it? I mean, definitely working together with the communities. So if we don't work with the communities, we cannot raise the awareness among the communities, and we cannot reduce, like the cancer incidence or the cancer survival, reduce the cancer survival, or like increase the cancer uptake, that kind of things. So we have so many things to discuss about, but like I'm like concerned about the time here. So to do these kind of things, we as a cancer project, and we are also recruiting volunteers to work directly with the communities as a project manager. I mean, like I work with the community volunteers as well, and then provide the training to them and to become the cancer champions. And then they work with the community peoples in the respective communities. We have 25 cancer champions at the moment, and project is looking forward to recruit more volunteers from the diverse communities. So I would love to hear from you that if anybody is interested to work with the project, to work for their communities, to raise the awareness about the cancer, so that we can prevent, or we can, raise the awareness about the prevention and early diagnosis in the different communities in waste trading or bauxite waste areas. So you are most welcome to do that one. So I would love to share this information with Cecily, and they give the information about the recruitment as well. So yes, thank you very much for this one.
Thank you, Nisa. Thank you for that.
So I had a lot of things to discuss, but just concerned about the time. And then maybe if you give me opportunity to raise the cancer awareness in your different group or sessions, I'll be happy to bring that sessions to your group as well.
Definitely, yeah. And the hub is there. There is a lot of information to be shared there, and that's the conversations too. So please bring that information, Nisa. We need it.
Yeah,
and
sure.
We are ending. It's 1 minute past the finishing time. But we can't go without hearing from Alice. 1 minute, Alice, because we have heard from you before. And then Tom Lake has got very useful information to share with us all. And then James will let us go.
Okay, thank you very much, everyone. Hi, I'm Alice Clifton from Community United West Berkshire. The reason coming to you guys is I'm asking for support, in the sense that we are doing Living with COVID, or Living with Long COVID project that has been launched with the Berkshire Long COVID Integrated Service with Royal Berkshire Hospital. We are doing a podcast with the experience of different communities. So if you are interested, please do speak to Cecily to come and talk to us. Or I have put out some things in the chat, because I do think that, we are going to be living with the COVID. A lot of people are not aware of long COVID. We had a webinar a couple of weeks ago whereby one of the doctors from the hospital turned around and said, long COVID is real. So do come and speak to us, and then we can help you as much as we can. What we are trying to do is close the gap so that people understand about long COVID, get the information, do the prevention, and make the service better for you. Thank you.
Thank you, Alice. And you're doing so many other projects in West Berkshire. So our communities are well represented there through your work. So thank you for that.
Thank you.
Thank you. And then we have Tom Lake with the South Reading Voices.
Thank you very much. I wonder if I can, is it possible for me to share a single screen, do you think, Cecily?
Yeah,
available?
Yeah, let me.
Thank you. While you're doing that, I'll just say we've got our organization, is a very small organization, South Reading Patient Voice, has been running for some time. We encourage patient engagement and finding out about the NHS and the way it's organized in our area. And we have supported patient participation groups to get more active and engage better. That has been quite useful, I think. Now we're just running a little pilot survey about unmet medical need. What do people think? Now, I think it's really important to reach out. We do a lot of responding to people coming in with complaints or that sort of thing, or discussions, but it's also important, I think, just to reach out and see what people think. It's only a pilot, it can't be an accurate study of statistics, but just to see what people think about unmet medical need. So this is a survey that we're running with it's pretty easy to get a hold of it, online survey. So here it is at the bottom. This is at the bottom is the way you find it on the internet. healthsurvey.uk, unmet medical need. If you're able to pass this on, we'd be very grateful. We'd like to get some responses and just to see what people think about their medical needs. So that's a way, it's a kind of way of raising a signal. We ask a little bit about, are you worried? Have you pain? Do you, what kind of thing is it? And then that's all we're doing. It's quite anonymous, pretty much anonymous. We ask roughly where you live, which ward you live in. But just to get some ideas, and perhaps that will be useful to people who want to look into it in much more detail. Thank you very much. And just to say, for anyone, I'm one of the elected governors for Berkshire Healthcare. You've heard from our chair, Martin Iwicker, but Paul Myerscough and myself are here in the meeting. And if anyone would like to talk to us about any issue concerned with that secondary mental health care provision, or especially somebody who like to think, well, I'd like to be a governor in the future when we have an election, please get in touch with us through Cecily. Thank you very much.
Thank you. Thank you so much, Tom, for that great representation. Clearly, we have a rich community around us. And within our workplaces, we know we are represented everywhere, whether it is in the council or within NHS. Health and social care is where we have got the greatest representation. And we experience the same issues we are talking about here, the inequalities. And with us, we have Mollis and Sanya. I hope Sanya is still around, representatives of the BME network within Berkshire Healthcare. And I'm sure there was somebody also from the council. So Mollis, if you can just say hello to us, and Sanya, if you're around.
Yes, thank you, Cecily. And thank you for inviting me to this meeting. Having listened to different presentations of what is happening in the community in terms of inequalities, refugees, and mental health, it is quite interesting. Myself, let me introduce myself first. My name is Maurice Kakungu. I'm the clinical team lead in Newbury Community Mental Health Team. I'm the newly elected deputy chair of the BEM community for Berkshire Healthcare Trust. So I'll be so much interested in working with the entire community, developing and collaborating healthy relations with all ethnicities so that everyone's healthcare needs are met and we have an equal opportunity in health, in jobs, in everything that we do in life, in terms of our human rights. So I'm a fan of human activist, although I'm not a human activist, human rights activist. I'm a healthcare professional, but the role that I've taken of late is advocating, being the voice for the voiceless within Berkshire Healthcare Trust, a group that seeks to grow and reach to a stage where they feel they are having enough privileges like the other majority groups that have existed for a long time. And working with all of you will bring a lot of ideas for me and Sanya in order to shape our trust, in order to meet our healthcare outcomes, in order to improve our services for both patients and our staff within our community. I think I would probably invite questions from you because I'm someone who I do not prefer talking a lot without hearing from others. It is important to hear the concerns of others and how we can help going forward. Thank you, Cecily.
Yeah, thank you so much, Mollis. I'm sure people will have questions, but maybe for next time. But our workforce comes from these communities, and it is important that we engage with what is going on within our services. So Eva, welcome back. We lost you a bit. And I did James' slide. So yeah, it's James, but welcome back, Eva.
Okay, good afternoon, everybody. Is Eva back in the house?
She is back, yeah.
Okay. I would like to thank you all. And I think one thing I know for sure when we talk about health inequalities, it's not just about us that are being marginalized, also people on the other side as well. For example, like myself, a healthcare provider. Indeed, I work for BHFT, and one of the things Martin said earlier was that we're trying to locate into the community to work closer to with the people that we serve and people who feel that they are marginalized. So I'm here at ACA and the Wellbeing Hub. I'm here 2 days a week, to provide support individually, also as a group. But really what I'm here this afternoon is to really ask all of us to really manage all the excitement and also the anxiety and the emotional challenges that this topic can always bring to us. Talking from as a being member, it's really important for all of us to understand that there are so many disparities that we can talk about the whole day. I have data here, but I'm not going to because we don't have any time. I'm just going to use 2 of those data here just to highlight some of the things that are very close to me. If we look at 24% of all deaths in England and Wales in 2019 were caused by cardiovascular disease in Black and minority ethnic group. That's a huge package, if you like, and it's all around heart issues, problem to do stress and all those things. Depression can also cause a lot of issues to do physical health problems. So many of you mentioned that. So that's one statistic that we can look at and see 24%, and that's a huge package, a huge percentage of us, the BAME community, really dying because of one illness. And there's also one that also is close to us as men, and I think Tariq mentioned that, which is in the UK, the African and Caribbean men are up to 3% more likely to develop prostate cancer. And I think these are statistics, but they are really meant to highlight and also to activate and to instigate our thinking. And it's also important to realize something that I've always said, that equality is an ideal. But if we spend time just focusing it as an ideal, we are not going to really achieve it, because it's like waiting for you to win the lottery and then support people when you can start to do little things, like running the marathon, maybe just visiting them, maybe talking to them, asking them about their issues, rather than waiting for you to win the lottery to before you can actually support them. That is really what that means. So we may never reach our aim if we're just thinking, playing around equality as an idea. That's where we want to be in 5 years' time. But how can we get there if we don't do anything? So for me, really, it's about these little things that we are doing. And I have kind of created a triangle here where, because as a CBT therapist, this is really important to me. That's the reason why I'm actually based in the community, representing BHFT and talking therapists as well. And Tariq mentioned about the refugee guys that we've been happy. I mean, when I met them, we didn't have any communication, even though we all came from Africa, but we managed to work together. And I think when people say, I don't have the right to help, to support, to reach out, I think we need to reflect a little bit more. Because who determines what the right tool is? Is it not the patient or the individual you're going to meet? They can tell you that, look, because you can't communicate with me, I'm not going to engage with you, but you can find a way around. And I was able to find a way around with these refugee guys. We went to the refugee support group. We went to the working center. They've already started doing well. They come to the hub and they're a lot more happier than when I met them. And I think Tariq mentioned a lot about the impact if we don't provide support for people. So I look at the triangle of access. How do people access? It's not just about referral, say, look, there's a service over there, go and engage. It's really about the right language, the right information. Is it appropriate for them? Do they know what they're going to do? Do they know that service? Does that service really understand them? Will they be able to really manage their difficulties? And the second bit really is the engagement bit. And the engagement bit also, I think quite people mention about the 3 C's: you collaborate, you cooperate, you co-produce. But these are all big terms that we use. Who do we co-produce with? You know, how do we co-produce? How do we really collaborate? How do we understand? So we need to look at how do we position ourselves around people we serve, you know. And I think somebody mentioned that sometimes it's misunderstanding. We don't know. Of course, there are cultural disparities, but when it comes to delivery of health, I think health should not have any barrier because of cultural issues. You can actually adapt, and that takes me to the next item on my triangle: adaptation. How ready are we to adapt? We're not adapting them to us, but we adapt the service to them, to their needs, you know, and that's really quite key. And that's another area where my role really in talking therapy is trying to really understand and work with, to adapt treatment to the need of the people is really important. It's really about understanding their culture. You don't need to be competent in all cultural areas because it's not possible. And it's really about cultural humility, to look at some of the barriers that we also as service providers have in terms of reaching out. But it's also on the other hand also, because when we look at the gaps, mind the gap, if you're in London, in the underground, that's a frequent thing I came to understand when I first came to this country, mind the gap. I said, what does that mean? Basically, it's really about trying to mind the gap between you and the railway line or the train coming, you know, so it's really about minding the gap. How do we do it? We need to work it together. I think Martin mentioned about us community champions or members to be involved. I think sometimes it's important for us to reflect on our own hesitation, on our own concern, our fears, which is there because of previous experiences. And I think Councillor Alice was talking about how often do we hear the same statistics, and every year we come to the same statistics. Yes, indeed, they exist, but if we are not also engaging on the other hand, it's not going to be easy to move the statistic forward. So we have to do some work. We have to be able to engage with services. We have to look at also some of our own cultural practices that might be holding us back. And I'm working with faith leaders to look at how we can all support people to access services, because sometimes God himself, we need extra support. So, and those extra support can only come from professionals, doctors, social services, and all of those things. So we need to work together. And I think I will go on and on if we talk about how we need cultural parity to be achieved. But for this moment, I would like to leave all of us in terms of our own barriers that we have, our own hesitation perhaps, what we need to look at in terms of moving forward. And I really want to invite all the service providers, perhaps if we can all come together to look at how can we collectively meet the needs of our people or the people we serve, because we all have different ideas, but we are actually focusing on the same people or the same community. So why can't we share, collaborate, and make sure that we work hand in hand so that we minimize wastage and also optimize resources? I think that would be my own plea this afternoon for us to begin to work together, because there's so much energy, so much asset, and so much enthusiasm, so much motivation, but the energy is not going forward, and we need to push it forward by coming together to deliver. I would like to thank you all, and I'm really enjoying myself at the hub. And it's on Oxford Road, which is a frontline road in Reading. So if you just shopping along Oxford Road, just pop in and you'll be treated by Eva and her team. Thank you again. Bye-bye.
Thank you very much. And thank you for attending our conference today. And I just want to wish everybody a good afternoon and enjoy the sunshine or the snow. Not very sure what's going to happen today, but thank you, everybody, and have a good afternoon.
Thank you.
Thank you.
Bye.
Thank you. Bye-bye.
Thanks, everyone.
Thank you. Bye.
Bye. Bye.